Hey all, so today we will discuss about leukoplakia, which is very important topic for UG point of view, and it is asked with two most important classification. That is, the first one is classify premalignant lesions and conditions. So leukoplakia is one of the precancerous or premalignant lesion, and the second one is red and white lesions. So basically, it is asked to classify red and white lesions, and leukoplakia is one of the white lesion, right? So now let's discuss what is leukoplakia. So leukoplakia is made up of two terms, that is leuko and plakia, where leuko means white and plakia means a patch which is white in color and present on the mucosa of our oral cavity. So any white patch on mucosa which cannot be rubbed off or scraped off. You have seen several white lesions like candidiasis. In candidiasis, you have seen that the lesions are basically or can be scraped off. But in leukoplakia, this lesion cannot be scraped off. Leukoplakia cannot be scraped off or rubbed off, and which cannot be attributed to any other diagnosable disease. So basically, it is explaining that leukoplakia is very unique in nature. It cannot be attributed to any other diagnosable disease. It works on a negative diagnosis criteria. So a lesion which is a lichen planus or psoriasis or any other white lesion cannot be a leukoplakia. You have to diagnose it with the negative diagnostic criteria. Now, to make it more clear, WHO has also given a definition of leukoplakia. So it has two parts. So the first part says that it is a whitish patch or plaque that cannot be characterized clinically or pathologically as any other disease. So as we have discussed, leukoplakia is unique in nature because it is not having, or it is diagnosed basically on the exclusion criteria. If you have seen a white lesion, it can be any lesion like psoriasis, or it can be lichen planus, or it can be due to some chronic irritation. But in all the white lesions, you have seen some pathognomic features, or you have seen some definitive criteria for explaining that this lesion can be a lichen planus or psoriasis or anything else. But in leukoplakia is so unique that it is not having any pathognomic features or any definitive criteria for explaining that this white lesion is a leukoplakia. So it is diagnosed based on the exclusion criteria. You have to remember this. Leukoplakia is always diagnosed on the basis of exclusion criteria. Therefore, it is a negative diagnosis basically. I hope this is clear. And the second part states that which is not associated with any other physical or chemical causative agent except the use of tobacco. Tobacco is considered as the main etiology behind leukoplakia. There is one more definition of leukoplakia given by Excel in 1996. Let me read it out for you. It is predominantly white lesion of the oral mucosa that cannot be characterized as any other definable lesion and will transform into a cancer. Now, how to classify leukoplakia? So there are two main categories. So the first one is homogeneous and second one is non-homogeneous. So the homogeneous means that lesions are uniformly white. So it is white in color. Whereas in non-homogeneous, the lesion is a combination of both white and red patches. So homogeneous is also classified or subclassified under, it can be flat, it can be corrugated or pumice-like or wrinkled. Whereas non-homogeneous is nodular or speckled, verrucous or ulcerated, and erythroleukoplakia. So these are the subdivisions of homogeneous and non-homogeneous. Now we will discuss the types of homogeneous leukoplakia. So the first one is flat, which is having a smooth surface. Now the second one is corrugated. Corrugated basically means that there is some folds present in the lesion, like a beach at ebbing tide. So you can see here, whenever waves are there, they make a pattern over the beach or the sand, like some folds. So this means a corrugated pattern basically. And the next one is pumice like, with the pattern of fine lines. So there will be white fine lines visible in the lesion. And the next one is wrinkled like a dry, cracked mud surface. That I hope that's clear from this picture, like a dry, cracked, and mud surface basically. The non-homogeneous types we will discuss later on in this video. Now, the leukoplakia can also be classified based on the risk of future development of oral cancer. As we know that leukoplakia is a premalignant lesion. So, the sites which are at higher risk of developing cancer are floor of the mouth, lateral or ventral surface of the tongue, and the soft palate. Whereas the dorsum of the tongue and the hard palate are considered at a lower risk of developing cancers, and rest of them are considered as intermediate group or intermediate sites. So this is the dorsum of the tongue, or you can say a dorsal surface of the tongue, which is at low risk of developing oral cancer, whereas high risk site is ventral surface of the tongue, or you can say the lateral or lateral borders of the tongue as well. I hope that's clear. Now we will discuss the etiology of leukoplakia. It can be due to local factors, it can be due to regional and systemic factors, or it can be idiopathic whenever we are unable to find any causative agent. So then we will say that the lesion is idiopathic, or it is also known as cryptogenic leukoplakia, right? So the first one is local factors, and the tobacco, as we know that it is the main causative agent of leukoplakia. Alcohol is also considered to be the causative agent of leukoplakia, because many cases have been seen to be associated with more alcohol consumption, right? Chronic irritation, candidal infection, and electromagnetic reaction and galvanism. So in galvanism, what happens? The current is generated in the oral cavity due to two different metals, which will give you some neuralgic pain and chronic irritation or inflammation of the mucosa. That's why the mucosa gets white or keratinized in nature, and we call that lesion as leukoplakia. So this is also one of the causative agent of or local factor of leukoplakia. After that, there are some regional and systemic factors also, such as syphilis, vitamin deficiency or nutritional deficiency, virus such as human papilloma virus or herpes simplex virus. So these are also associated with the leukoplakia. Some hormones, actinic radiations, conditions causing xerostomia or dry mouth may lead to leukoplakia, and some drugs. In syphilis, or more appropriately in tertiary syphilis, we can see white patches all over the tongue, because the causative agent of the syphilis, which is the spirochete, is more predilected towards the mobile tissue. So leukoplakia is seen on the tongue in tertiary syphilis. Now the clinical features of leukoplakia. So the age which is more commonly affected is in between 35 to 45 years and above. Now the gender, males are more affected because they are more addicted to tobacco products simply. But in Western world, we have seen that it is 1:1. Males and females are equally affected in Western areas. Now the common sites are buccal mucosa and commissures, but commissures or the lip commissures are more commonly affected than the buccal mucosa. So you should always remember commissures are more commonly affected with leukoplakia than buccal mucosa, but the lip lesions are more seen in men and the tongue lesions are more seen in women. or females. So you can also memorize this descending order of affected sites that are seen in leukoplakia. So first one is commissures, then buccal mucosa, then lips, after that tongue, palate, alveolar ridge, floor of the mouth, soft palate and gingiva. After that, what is the extent of the lesion? It can vary from a very small to a very large or well localized irregular patch to a very diffuse lesion. The lesion is white. Why the lesion is white or why it is keratinized? Firstly, whenever our body is irritated or there is some inflammation, the mucosa of our oral cavity tries to produce keratin as a defense mechanism. So the lesion is keratinized whenever there is a trauma. And why the lesion is white in color? Because of the saliva. Saliva wets this lesion and turns this lesion to be white in color. So here you can see heavy use of tobacco causes the lesion to turn into gray from white. So always remember, whenever there is a trauma or a chronic irritation, the mucosa will produce a lot of keratin as a result of chronic irritation, or you can say as a result of a defense mechanism, right? And saliva wets it and makes it appear white in color. So why the lesion is keratinized and why the lesion is white in color, I hope it is clear to you. Now the surface can be wrinkled or shriveled. Symptoms are, there are no symptoms as such, but you should always remember there will be increased thickness of the mucosa. If there is any ulcer or there is any nodule, the burning sensation may be felt by the patient. Now the clinical types of leukoplakia. Now the first one is preleukoplakia. So there is a white lesion present in the oral mucosa which is not that distinct, but it is present in a mild form. So it is also known as mild leukoplakia, or it is also known as thin leukoplakia or thin leukoplakia. So a lesion which is not distinct or it is not completely white lesion as seen in a perfect leukoplakia. Now the homogeneous form of leukoplakia, as we know that the homogeneous term states that the lesion should be completely white and it should be having only single texture. Homogeneous leukoplakia is the most common type and it accounts for 84% of the cases. Homogeneous leukoplakia is also known as thick leukoplakia and it is also known as leukoplakia simplex. Leukoplakia simplex. Now we will discuss about the non-homogeneous leukoplakia and the first one is ulcerated leukoplakia. In ulcerated, you can see a red area at the center which depicts an ulcer, and the peripheral area is somewhat white, or the pigmentation will be of or may be of varying intensities at the periphery. Now the next one is nodular leukoplakia, which is also known as leukoplakia erosiva or speckled leukoplakia. Here in this picture you can see small nodules present all over the lesion, or you can say scattered over an atrophic patch. This nodular leukoplakia is having a higher malignant potential. Nodules can be pinhead size or maybe even larger. Now we will discuss about the verrucous leukoplakia, which is also a type of non-homogeneous leukoplakia. It is also known as verruciform leukoplakia or leukoplakia verrucosa. So in this type of leukoplakia, you can see small projections, small papillary projections, which are sharp and blunt. The lesion is heavily keratinized. This is all about verrucous leukoplakia. Now the next is proliferative verrucous leukoplakia (PVL), which shows more exophytic growths or more papillary projections. there will be multiple keratotic plaque, and there is female predilection. There is one more important fact about PVL, that it is not associated with tobacco. Although leukoplakia is more prevalent in males and is associated with tobacco, but PVL is more seen in females and not associated with tobacco, which form PVL. And it is clinically and histopathologically similar to verrucous carcinoma or squamous cell carcinoma. So this is the most important facts about the PVL. Now the lesion may be a combination of both erythroplakia and a leukoplakia, means a red component and a white component is present in the lesion. Then we call that lesion as erythroleukoplakia. Now the staging system of oral leukoplakia. So the staging system is having two components. First one is size and second one is pathology. For size, letter L is used. For pathology, letter P is used. So L1 depicts less than 2 centimeter, L2 means 2 to 4 centimeter, L3 means more than 4 centimeter, and LX means size not specified. Similarly, P0 means no epithelial dysplasia, P1 means distinct epithelial dysplasia, and PX means dysplasia not specified. Now the stages. Stage 1 denotes L1P0. L1 means the size is less than 2 centimeter and P0 means there is no epithelial dysplasia. Stage 2 means L2P0. L2 means the size is in between 2 to 4 centimeter and P0 means or P0 means no epithelial dysplasia. Stage 3 L3P0. L3 means the size is greater than 4 centimeter and there is no epithelial dysplasia, or it can be L1, L2 with P1. P1 means there is distinct epithelial dysplasia. Now the stage 4, that is L3P1, when the size is greater than 4 centimeter and there is a distinct epithelial dysplasia, then we call that stage as stage 4. Now we will discuss about the diagnosis of leukoplakia. So clinically it is a white patch with history of tobacco chewing which cannot be rubbed off or scraped off, as we have read earlier. Now as we know that leukoplakia is just a clinical term, it is not having any specific histopathological features, but there should be some features that should be included in the biopsy report. These features are hyperkeratosis, can be orthokeratosis or parakeratosis. There should be acanthosis of epithelium, epithelial dysplasia should be there, liquefaction, degeneration, and basal cell hyperplasia. These are some of the features that should be there in the biopsy report. Now, what is epithelial dysplasia? So, epithelial dysplasia is basically disordered cellular development. And there are many features of epithelial dysplasia. Let's discuss them one by one. First feature is loss of polarity of the basal cells. Normally, the nucleus is present near the basement membrane. But in epithelial dysplasia, here you can see nucleus is present away from the basement membrane. Right. Now the second feature is presence of more than one layer of cells having basaloid appearance. So this is the basal layer of cells. Now here in epithelial dysplasia, you can see many layers of cells having basaloid appearance. Now the next point is increased nuclear cytoplasmic ratio. Normally it is 1:6 or 1:4, but as the nucleus increases in size, it may reach up to 1:1 in epithelial dysplasia. Now the fourth point, normally the retiridges taper or are parallel sided with blunt ends. So here you can see blunt ends normally. But in epithelial dysplasia, you can see broader or bulbous retiridges or drop-shaped retiridges, right? Now the next point is irregular epithelial stratification. Normally, the epithelium is arranged in distinct layers. But in epithelial dysplasia, there is disturbance in the arrangement of the layers of the cells. Now the next point is increased number of mitotic figures. As cells are really very active in epithelial dysplasia, therefore the number of mitotic figures are increased. Next point is cellular pleomorphism. Pleomorphism means the shape and size of cells are changed. So here you can see the size and the shape of the cells are changed due to epithelial dysplasia. Now the next point is nuclear hyperchromatism. Hyperchromatism is increased staining of the nucleus. So it becomes dark staining. The nucleus becomes dark staining, and it is due to the increased DNA content of the cells. In epithelial dysplasia, the nucleoli becomes prominent and enlarged. Feature is reduction of cellular cohesion. So as we know that cell to cell contact is maintained by desmosomes, but in epithelial dysplasia, these desmosomes are disrupted, or there are changes in the desmosomes that will lead to disrupted cell to cell contact. Now the next point is keratinization of single cell or cell groups in the prickle cell layer. As we know that in normal epithelium, only the uppermost layer of the epithelium is keratinized. But in epithelial dysplasia, we can see the prickle cell layer or the single cell keratinization is present. So now, depending upon the dysplastic features of the epithelium, leukoplakia can be divided into mild, moderate and severe forms. So the first one is mild dysplasia, which will show hyperkeratosis. Acanthosis. Acanthosis means thickening of the spinous layer cells. Right? And the dysplastic features will be seen in the basal 1/3 of the epithelium. So here you can see basal 1/3 of the cells are showing dysplastic features. Now second one is moderate dysplasia. This will also show hyperkeratosis, acanthosis, है ना? Then basal 2/3 of the cells will show dysplasia or dysplastic features. Now the third one is the severe form, which will show this plastic feature in more than 2/3 of the epithelium, and the superficial layers will show some stratification. Now leukoplakia is having malignant potential. So basically 0.3 to 10% of the cases may convert into some oral cancers, and it can be seen by with the help of toluidine blue testing. So this is the test which is done in order to see the malignant potential of the lesion. It is higher in women 6% than men. Men will show only 3.9% chances of getting oral cancer through leukoplakia. Now the factors which are at higher risk of malignant change. So the first one is persistence of lesion for several years. Female patient, lesion situated on the margins of the base of the tongue and floor of the mouth. Erosive lesions or non-homogeneous lesions, you can say, may show more malignant potential than combination of the above factors. So these are the factors which are at higher risk of malignant change. Now the differential diagnosis of leukoplakia. So as we know that leukoplakia is a white lesion, so mention all the white lesions that you know, like lichen planus, psoriasis, leukoedema, verruca vulgaris, cheek biting lesion, electrogalvanic white lesion, etc. Now the management of leukoplakia. First one is removal of all the causative agents that are causing leukoplakia. So first one is prohibition of smoking, and the second one is removal of chronic irritant and other etiological factors. Now vitamin therapy is given in order to have a faster recovery. So vitamin A, E and B complex are considered important in management of leukoplakia. Now the last one is surgical management. So the first one is conventional surgery, in which the lesion is removed via surgery. Now the second one is cryosurgery, in which a cryoprobe is taken, which is chilled via liquid nitrogen or pressurized nitrogen oxide gas, and this chilled probe is applied over the tissue in order to damage that tissue at minus 20 degrees centigrade. After that, the probe is thawed or warmed up and the tissue is damaged and removed via cryosurgery. Now the third one is fulguration, which is also known as electrocautery or electrosurgery, in which the tissues are damaged or destructed via high voltage electric current, and the action is controlled via a movable electrode. So these are some of the surgical ways of removing leukoplakia. And the last one is lasers. So what lasers do? They also damage or remove the lesion. So carbon dioxide lasers are most probably used, which are composed of carbon dioxide, nitrogen, and helium. So this was all about leukoplakia. Thanks for watching.